Hello, everyone. This is a quick pre-recorded talk to prepare you for the ventilation workshop that will occur in the last week of Pulmonary. The objectives are noted here, and I want to give a big warning. This is preparation only, and there will be a fair amount of material in terms of clinical management that is presented during the workshop that will not be covered here. So this is in contrast to all the other problem sets. This is not a pre-recorded worked solution. This is just to get you ready for class time. Let's start with a patient and a quick challenge. It's 2 years in the future, and this situation arises during your orthopedic ACE. We go to the OR and, of course, have a routine induction of anesthesia in this otherwise healthy patient. The resident chooses the settings noted here. And let's just go over what that looks like. I'm going to give you a representation of a ventilator, and there are several different interfaces. So this is not the only type of ventilator or parameters that you'll see in your clinical work. We've intubated the patient. Our circuit test looks good. And now we go from handbagging to mechanically ventilating the patient. These are the settings. You'll notice that in the modern version of ventilators, the ventilator will often test the compliance of the patient's lungs and trachea tube and circuit to gravitate towards the set pressures, which are a little bit different here. And we'll take a few minutes to equilibrate. Let's look at some of the controls that have been used. So the respiratory rate is a set value. Tidal volume is a set value. We're not going to really worry about these parameters at this time. We've used 5 a peak for some of the reasons we've talked about in class. This patient should not require a very high FiO2, so we're going to start at 40%. Trigger flow is just what effort would be required on the part of the patient to generate their own synchronous ventilation from the ventilator. And now if we look at the display, the waveforms displayed can be very helpful. So the highest pressure that we see, let me try a different color here, see if it looks a little better. The highest pressure displayed will be the peak inspiratory pressure. Notice I don't have that displayed on our current dashboard, but it commonly would be. And then after that peak pressure, we'll often see a dip that occurs down to a lower pressure, and this is the plateau pressure. Notice that we can also see the flows that occur during these phases, and that initial hard push of gas occurs and levels to get to our peak inspiratory pressure, and the sustained pressure occurs as the gas distributes through the lungs. Similarly, the actual volumes of the lung, there's a mechanical artifact where there's a slight dip in pressure in volume here, transiently at the beginning. But then the volume that is actually pushed into the patient's lungs, I actually should say into the circuit in patient's lungs, increases steadily. Notice the volume pauses here, and that the pressure is actually dropping as this volume dissipates through the lung. You don't have to get heavily into this yet, but if you do the work that some of your faculty does every day, then this will be of great interest to you. Let's also orient ourselves to patient monitor and what we would be looking at. So our patient here would not have invasive monitoring, and this would be fairly representative of what you would see. So we've got a heart rate of 105. Well, we know that's a little greater than absolute normal. We've got a 96% SAT. Well, that's pretty good usually, but is that good in a healthy MS2 who is actually on 40% oxygen? You may want to think about that a little bit. This blood pressure, well, it depends. Are they usually a little hypertensive? Then this isn't so good. If they're usually normal tensive, it's down a little bit, but is it down too much? Is it dangerous? We'll talk about all that in a little bit. And an end tidal of 48. Now, let's think about that for a little bit. If we think that you would expect a dead space of approximately this. And we think that it should still be, say, 0.2 with mechanical ventilation. You're not sure of that yet, but let's just test this hypothesis. We can't get an arterial CO2 short of drawing a blood gas, which is a little bit invasive in this circumstance, at this point anyway, unless other things manifest. So how would this all work out? Well, we know our end tidal CO2 is 48. So doing some basic algebra, how would we get there? So we're thinking the piece ACO2 could be in the neighborhood of 60. And this is a guesstimate. I want to emphasize that. But with a 0.2 dead space, VD over VT, then this is how the numbers will work out. And what else do we have here? Our respiratory rate is, as set, 13. All right, so now let's try to put that all together. And what I would ask you is the following questions. Are you concerned about oxygenation and ventilation in this circumstance? And are there adjustments that you would make? A couple of the things that I would be thinking about might be, is my current minute ventilation, which is going to be about 5.2 liters per minute, adequate? If not, then it would be as simple as increasing that. If it is a reasonable minute ventilation and I still have hypercapnia, then is there an increased production of CO2, or is there a decreased efficiency of ventilation? In other words, that VDVT is worse than I thought, and we're starting to accumulate CO2. And this opens a wide range of differentials: increased VO2 with hypermetabolic situation, fever, malignant hypothermia, neuromalignant syndrome. And so that's one bucket. Increased VT makes me concerned about right ventricular function, volume status, the way I'm using my ventilator, and so on. The vital signs: I've got an increased heart rate, and that might not be normal for this well-conditioned athletic MS2, but after induction of anesthesia and placement of an endotracheal tube, it might not be surprising at all. And we could probably wait a bit and make sure that that settles and possibly treat it. In terms of saturation, if we think about something called the PF ratio, which is commonly used in our hospital in the ICUs, or some variation thereof, that's just the PaO2 over the FiO2 as a fraction. So we have to, again, we're not going to draw blood gas. We have to guesstimate what the PaO2 is. And it's, maybe in the range of say 100. Let's use that as a guesstimate. So that's 100 over 0.4. That's about 250. And I'm going to leave it to you to look for PF ratio. And you might want to look in the ARDS literature to get a sense of where this came from. But it's used for considering at least general efficiency of oxygenation and whether you think this is good or not. That brings up a whole host of other issues in terms of clinical management of what is normal as we sit here, what is normal for a patient who's in an abnormal situation, like having anesthesia induced, being intubated and having positive pressure ventilation, what is abnormally abnormal and requires, considered attention, and what is dangerously abnormal and will really hurt the patient if we don't respond in a very quick fashion. All right, look forward to seeing you in the workshop. And let me, as always, know if there are any questions. Thanks.